I would like to invite Dr. Lee for the last lecture of the day about new neuroimaging modalities.
So really this is not that new, it's just some things that you need to know. If you're an ophthalmologist, these are the 5 neuroimaging studies that you kind of have to know to take care of neuro-ophthalmology patients. It's the companion talk to the first talk I gave you. So the 5 studies are FLAIR, fluid attenuation inversion recovery. And the thing you need that for is for demyelinating disease. Optic neuritis would be the prototype, but INO and new onset nystagmus in young people would be 2 other indications. You need to know about fat suppression for anything that's involving the optic nerve. You need to know about CTA and MRA combination for third nerve palsy, which we touched on before, but I'll show you in more detail now. You need to know about diffusion-weighted imaging, DWI, and that's for acute stroke. That's top of the basilar syndrome and acute homonymous hemianopsis. And you need to know about MR venogram for papilledema, and this is to tie in with Peter Savino's talk on pseudotumor. So, FLAIR. FLAIR is fluid attenuation inversion recovery. Remember we said on T2 that on T2 the CSF is bright, but it's too bright, so we want to turn off the CSF signal and turn it black, but I still want to see pathologic white matter disease. So when you're looking for white matter disease, and for a whole host of other pathologic T2 conditions, we want to turn off the CSF signal and only show pathologic T2 chains. So if a patient has optic neuritis, we're looking for periventricular white matter disease. That's going to be seen easier if we suppress the CSF with FLAIR. And one of the things that Peter showed you was that the break point for prognosis for multiple sclerosis, the development of clinically definite MS in this slide at year 15, is between 0 and any lesion. That is, even if you have 1 lesion on your MRI scan at onset, your chance of MS is tremendously higher at year 15 than if you had no lesions. So finding that 1 lesion is a critically important task when you're seeing the patient who only has a monophasic condition, optic neuritis. So the critical break point is between a totally normal MR and even 1 MR T2 lesion. You need to give contrast, because if you don't give contrast, meningioma will not show up. That's my house in Texas at night. You can't see squat. Fat suppression is necessary when you're looking at lesions in the orbit with contrast because, as I mentioned to you in the first talk, on the T1 weighted study, the fat is very bright. But notice how the fat is too bright. So just like the CSF is too bright on T2, the fat is too bright on T1. So we want to suppress this normal fat signal and take it away. And the reason that's important with post-gadolinium MR of the orbit is we want to see enhancement in the orbit and especially the optic nerve. So this is a non-fat suppressed T1 weighted study. The fat is very bright on this T1 weighted study of the orbit, but you can see nicely the globe, the optic nerve, and the muscles. This is post-contrast. You see the gadolinium is pouring out into the nose and is in the cavernous sinus and the stalk. Can you tell if that optic nerve is enhancing or has a tumor in it? I cannot. And the reason you cannot is because the very bright fat is superimposed on the optic nerve. And so the gadolinium, if it was there, will not be seen if you do not suppress the fat. So, if you have a no fat suppression, you can't see the nerve. If you have fat suppression, the fat has been suppressed out, and now I can see that there is gadolinium enhancement along this sheath, consistent with this sheath meningioma. Far and away, this is the most common reason an ophthalmologist would order an MR and get a normal report, and yet the patient still has a tumor in the orbit, an optic nerve sheath meningioma in this case. And that's what you get when you have fat and gadolinium with no fat suppression. Polar bear in a snowstorm. White on white, you can't see. There's your polar bear. So, as I mentioned to you before, one of the protocols that you need to take home with you to your neuroradiologist is, I am going to have cases of unilateral or bilateral optic neuropathy. I need you to protocol for me the optic nerve. This will include the orbit and the head but just follow the course of the optic nerve. I need fat to be suppressed, and I need a post-contrast fat suppression image of the orbit so I can see this enhancement. Because I'm looking for demyelinating disease, I need a sagittal and axial flare, fluid attenuation recovery, the CSF suppression sequence, to look for periventricular white matter lesions. The sagittal is really useful, in my opinion, for looking for the Dawson's fingers, the corpus callosal lesions that are seen in demyelinating disease. This is one study at our institution. It is not 2 slots, and your neuroradiologist will thank you if you're not taking up 2 patient slots with your MR head orbit gadolinium study. So you need to have the orbit, FAT-SAT, and the sagittal axial flare. The 2 imaging studies for angiography that have markedly reduced the number of angiograms that I order are MRA and CTA. MRA is MR angiography. Remember we talked about the flow void. So rapidly flowing blood on MR generates no signal. That's flow void. But you can find that the reverse, the signal, on MRA. So we're going to take that flow void signal and make it bright. Here is an example of an aneurysm seen on MRA. Most places, however, have shifted over to CTA. CTA uses contrast material, the iodinated contrast, which, as you know with CT, blocks the X-ray, and we can reformat that with the 3-dimensional CT and show aneurysm, even this aneurysm at the skull base. At our institution, CTA is the preferred modality. They're neck and neck. Every year, one supplants the other by maybe a 1 or 2% sensitivity and specificity. But for an ophthalmologist, a properly performed MRA or CTA has a 98% sensitivity for the detection of an aneurysm producing a third nerve palsy. So if the suspicion for aneurysm is moderate or low, a CTA alone, followed by MRA combination, is probably good enough. If, however, you still think they have an aneurysm, or your CTA is not very good, or doesn't show the skull base, or as artifact, or they can't rotate this image around and show you the posterior communicating artery, then you are stuck with catheter angiogram for that person. So again, pre-test likelihood of disease is much more powerful than the test. If you think they have an aneurysm and they have a pupil-involved third nerve palsy with the worst headache of their life, unless they can show you that posterior communicating artery 360 degrees in a rotational format all the way around, you probably are going to be stuck with catheter angiogram. So this is the PCOM aneurysm right here, and you can see how nicely the MRA and the non-catheter angiography studies can demonstrate this. So this is the recommended screening strategy at our institution. So if you've got pupil blown third nerve palsy, that's going to get a non-contrast CT for subarachnoid hemorrhage followed by CTA. If it's negative, then you still need to do an MRA combination because you're looking for non-aneurysmal causes of third nerve palsy, like tumor and apoplexy and things that could be missed on a CT scan. If you're not 100% confident in these 2 studies, you're going to proceed to catheter angiogram. If your reading is not good, the quality isn't good, or you for some reason think they have an aneurysm. If you have partial palsy, just a divisional palsy, or the pupil is stone cold normal and the lid is down and all the muscles are involved and they're a vascular path, partial palsy at our institution still gets CT-CTA, but you could skip maybe the MRA, but if you want to perform it, it's okay. If both of these are negative, then you can stop, because this is 98% sensitive to detection of aneurysm. Same thing if the pupil is slightly larger, but the palsy is complete and they're a vascular path. They had surgery in this eye for cataract, or the pupil is reactive, but it's not as reactive as the other eye, or 10 million reasons why the pupil might be quote-unquote partial, like diabetes or some other reason. In that setting, non-contrast CT-CTA combination followed by MRA is probably good enough. But if you think they have an aneurysm in any of these 3 scenarios, or if this study combination is not good enough, you still might do an angiogram. This has to be individualized. The only person you can get away without imaging is the complete palsy. Lid is totally down, all the muscles of 3 are out, and the pupil is stone cold normal. That is a pupil spared, isolated, vasculopathic third nerve palsy. No one would fault you if you did an MRI, MRA on that person right there, as Peter Savino said before. And many of my colleagues recommend MR, MRA even for an isolated pupil, totally normal third nerve palsy. In the U.S., many centers will do this. But I don't think you have to. I'm still old school on that. It'd be interesting to hear what my colleagues have to say. I'm going to scoot over to diffusion-weighted imaging, DWI. Diffusion-weighted imaging is a specialized MR technique. It measures the signal from diffusion of water. Normally, the water molecules that are in the extracellular space are randomly moving. That's just Brownian motion. And their ability to diffuse is not restricted by anything. If, however, you restrict the ability of the water to diffuse, it will generate bright signal on the DWI, the diffusion-weighted imaging. So the ability of the water molecules to diffuse between the intracellular and extracellular space is allowed by that permeability of the cell membranes in your brain. And so when you have an acute cerebral infarction, you'll get cytotoxic edema. Cytotoxic edema means the cell dies. When the cell dies, it swells up. When it swells up, the water can't diffuse properly. When the water can't diffuse properly, it gets restricted diffusion that shows up as bright signal on DWI. And the reason it's important is conventional structural T2 MR might show nothing. So this person's hemiparetic and aphasic. There's no signal abnormality on the T2, and yet the diffusion-weighted imaging shows that they've got a hyperacute infarct in progress. Every year I see 2 patients referred to me with a normal MR, even though they are having a stroke, because the diffusion wasn't good enough, or they just used the conventional MR only and no DWI was performed. In the U.S., DWI is quickly becoming the standard of care for stroke and for all MRs. Whether you want DWI or not, you get it. But at some places, you have to order it. And then Peter talked to you about papilledema, young obese female. That's the prototype for pseudotumor cerebri in the United States. And one of the problems is, in this 30-year-old papilledema patient with headache and a non-localizing increase in intracranial pressure-related 6th nerve palsy, the MR comes to you as negative, the spinal tap is normal, but the opening pressure is 34. Diagnosis pseudotumor cerebri. MR venogram is necessary even for this person who, for all the world, should just have idiopathic pseudotumor. There's no way to differentiate sinus thrombosis, venous sinus thrombosis, from idiopathic pseudotumor clinically. And this is a time-of-flight MR venogram where no contrast is given. And you can see there's this divot right there. There's this poor flow in this left transverse sinus. There's poor flow down the jugular after traveling down the transverse in the sigmoid sinus. And before we started giving the contrast material, we would routinely get these non-contrast time-of-flight MR venograms, and they would be read out like this. We cannot exclude sinus thrombosis. Maybe that's atretic, maybe it's no flow. Because what you're looking for is, we want to see the entire anatomy, the superior sagittal sinus, the transverse sinus, the torcular, the sigmoid, and down the jug. Flow, demonstrated by this bright signal, has to be seen all the way down in order for us to be sure that the venous sinus system is open. And that's just the thing you would want to keep in your head. Just keep that anatomic picture in your head, because what we're looking for is divots, atresia, or narrowing, blockage. So this is that time-of-flight MR venogram. No gadolinium contrast was given here. Same day, same patient, gadolinium contrast MR venogram. All of the signal abnormalities that were seen on the time-of-flight MR venogram are gone, because that's artifact. So if you're going to go to the trouble of ordering an MR venogram, you have to give gadolinium contrast and have timed bolus contrast MR venogram. Otherwise, you're going to end up with somewhere between 30 and 40% of the readings of these MRVs suggestive of sinus thrombosis, and you will be admitting and anticoagulating patients who just have run-of-the-mill pseudotumor cerebri. 90% of patients who have just run-of-the-mill idiopathic pseudotumor cerebri have some narrowing in their transverse sinus on time-of-flight or phase contrast MR venogram. So if you don't do the contrast material, you'll get these artifacts. Contrast material eliminates those artifacts because we're actually visualizing gadolinium inside the venous system, and that's not susceptible to the flow-related artifacts that we see in time of flight or phase contrast MR venogram. If the patient is of the typical body habitus, and this is like more than 3/4 of my patients with pseudotumor already have an image on the outside. They come to me with an MRI, but they don't have an MR venogram. If they're typical body habitus, obese, young female, I treat them and it goes away. I don't make them have another MR venogram. But if they're a man, thin, or elderly, I make them have a contrast MR venogram because that's atypical for the prototype of pseudotumor cerebri on an idiopathic basis. If they have any other symptoms to suggest venous sinus thrombosis or risk factors, I make them have an MR venogram. But my standard workup for fresh patients who have not had any imaging is an MRI with contrast and a contrast MR venogram. So in summary, the 5 imaging studies that you as an ophthalmologist or a neurologist treating their ophthalmic patients needs to know. You need to know about fluid attenuation, inversion, recovery, FLAIR, and that's for demyelinating monophasic attacks like optic neuritis, INO, and nystagmus, because even one white matter lesion is prognostic for the development of MS at year 15. You need to know about fat suppression with gadolinium, because that's polar bear in a snowstorm or my house at night in Texas if you don't give gadolinium and if you don't suppress the fat for any patient with optic neuropathy, and you need to call your radiologist and get an optic nerve protocol. You need to know that CTA is currently our first-line study for third nerve palsy with pupil involvement with a non-contrast CT to look for subarachnoid hemorrhage, and then you're going to follow that study with MRI, MRA for non-aneurysmal causes of third nerve palsy. You need to know about diffusion-weighted imaging, DWI. The settings that an ophthalmologist would see this in is acute homonymous hemianopsia and top of the basilar syndrome. The structural imaging with standard T2 conventional MR may be normal in that setting. You need to know about MR venography for cerebral venous sinus thrombosis in patients who look for all the word like idiopathic pseudotumor cerebri, but you must give the contrast material on the MRV to eliminate the flow-related artifacts of non-contrast, time of flight, and phase contrast MR venography. And I thank you for your time and attention.